Okay, so as I said, today's part 2, and we are focusing on psychotropic drugs optimization. So if we go to the next slide, Trang, please. So the agenda. So we wanted to take you through just a general introduction and principles around STOMP. We did touch base on this on the first webinar, so we'll just go through some of that. As a recap, and that will lead us on to some of the register validation work that Tom, Trang and I have been doing. So we'll share that information with you and some of the STOMP data so far. Thomas will then take us through some of the resources that are available for primary care on psychotropic drugs optimization in practice. And then we've got Dr. Amy, who will take us through some case studies specifically on psychotropic drug reductions. So if we go to the next slide. So STOMP. So just a recap, like I said, what does STOMP aim to achieve? So as we know, STOMP stands for stopping the over-medication of people with an intellectual disability, so a learning disability, autism, or both. And it is a project supported by NHS England. It's primarily aimed at reducing these inappropriate prescribing of psychotropic medication, which is often used to manage behaviour that might be deemed challenging in the absence of a documented mental health diagnosis. So we know from sort of national data, the Public Health England data, around 30 to 35,000 patients with a learning disability are taking these medicines when they may not have the health conditions the medicines are for. And unfortunately, children and young people are also prescribed them. So we know with psychotropic medicines, when they're taken for too long or taken at a too high of a dose or for the wrong reasons, it can cause many unwanted side effects. So these are things like putting on weight. Often these patients feel they're drugged up, and then there's also some serious problems with their physical health. So the serious case review, which you guys may have read into, which was done at the Winterbourne View Hospital, highlighted some of the inappropriate use of the medication and the need to take action. So what is it that we're aiming to do? So STOMP is all about helping people with a learning disability to stay well and ultimately have a good quality of life. We want to be able to ensure that all staff within the organisation have an understanding of psychotropic medication, even if it's basic understanding of these medicines, including why it's being used and some of the potential side effects that they can have. Making sure that patients and their relatives and carers are feeling empowered to speak up if there are any concerns about someone receiving an inappropriate medication. And also actively exploring alternatives, because it might not be fixed by something, just a medicine. There are non-pharmacological approaches such as positive behavioural support, which may be better for the patient rather than just adding medicines onto their medication regime. We want to make sure that these patients and their circle of support are fully informed about their medication and they're involved in decisions to do with their care. And if psychotropic medicines are needed, then it's started, reviewed and monitored in line with the local NICE guidelines and the South East London guidelines. So if we go to the second slide. So we wanted to just share some of the work our team have been doing. So it stretches from all the way back in June 21 up until December 22. We've done a lot of work around learning disability register validation. So these are the registers in primary care. And we've been looking at these registers, essentially two main cohorts. The first cohort are those that are already on the learning disability register to see whether they truly need to be on the register. And the second cohort are patients that may have a diagnosis to suggest an LD, but for whatever reason aren't on the register. The whole work came about looking at the prevalence and improving the accuracy of the registers. You can see in the box at the top the breakdown of the prevalence across the 6 boroughs in South East London. where everyone's kind of sitting at the same sort of amount, but Southeast London as a whole, the average prevalence is about 0.47%, which is just under national prevalence. But the estimated prevalence is 2.2. So a lot of work that really needs to be done across sort of a national scheme. So out of the practices we've visited so far, so this is across the 6 boroughs. We have visited 31 practices, so reviewed 1,607 patients. And out of that, we have recommended 185 patients to go onto the register. So that's equivalent to about 12%. Out of these 185, 75 patients were under the age of 14. So these patients don't yet qualify for the annual health check, but once they go up to 14 and above, the AHC can be offered, and also referral to community LD services can be made if needed, and any reasonable adjustments that need to be picked up for this cohort of patients. 95 patients were recommended to be removed from the register, so it's quite a significant amount that need to come off. And the main sort of reason around this was the ambiguity between learning difficulty and learning disability. We found patients were often had a learning difficulty, but were on the register and didn't really need to be. So those patients were removed. And obviously this contributes to increasing the GP's capacity for more of those complex patients, and also addressing some of the incorrect codes. If we go to the next slide, Trang. So with regards to STOMP, so out of the 31 practices, 1,194 patients were on the LD register. And so if you look at the pie chart on the left-hand side, so 609 patients out of the 1,194 were on psychotropic medicines, at least one or more. Now, if we delve into that further and look at the pie chart on the right-hand side, I guess this is the most alarming figure for us, the red part. So 49% of these patients were on the LD register with at least one or more psychotropic medication without a mental health diagnosis. And really, that's what we want to focus on in the future once we've started progressing a bit more with the register validation work. If we go to the next slide. So we've also been looking at children and young people. So we've done some work with a consultant paediatrician at one of the local trusts to cross-check CYP, so children and young people, to make sure they are actually on the LD register. So these patients, we had a list of patients, they have a definitive LD diagnosis, they're under the community teams, but there was a lot of ambiguity whether they were on the register and therefore receiving their reasonable adjustments and annual health checks if they were above the age of 14. So the breakdown you can see on the table on the left-hand side, a lot of these patients fell under the Lewisham borough, but that's because the community centre was in Lewisham, so a lot of the patients are Lewisham patients. But we had a look at these patients for the logins that we've got, and we found that 41% needed to be added on the register. So it just showed the gap where they were being diagnosed by the specialist team, but they weren't being added onto the GP system, which meant they weren't getting their reasonable adjustments and anything else, any access to services that they may benefit from. So this work is still work in progress. We're still waiting for some logins and some access to some of the practices, but we just wanted to include it on the slide show today, just to show the value of the work and the gap that these CYP patients could be falling in between if we're not adding them onto the register. If we go to the next slide. So we've got some Menti questions for the team today. Trang will take us through it, and I think she's going to put a QR code up and an access code for everyone to try and get onto it. There we are.
Yes, I'm going to try and do my best with technology, so bear with me. So we would like you to answer some questions, just a few, just to see where we're at in terms of audience-wise. So if you can either scan the QR code and it takes you straight to the question, or you can manually do onto the menti.com and then put this code on. So what I'll do is I'll give you just a few seconds to do that, or wake up. Everyone managed to get in yet? Right. That should take me to where we at. So the first question is, on the scale of 1 to 10, 1 not so confident and 10 being very confident, how confident are you with the principles of STOMP? So we have lots and lots of people participating. That's great. So 22 people so far. I think we've got about 50 people in the audience. So I'll give it a few, a little bit more time so that everyone can have a go. Yes, lots and lots. So majorities round about just under midway. So 4. So 35 of us are on the 4 at the moment. Any more joiners? Don't be shy. All right. So I don't seem to see any more. So I will move on to the next question, if that's okay. So the next question is, currently, how would you rate your service to support people with learning disability in relation to STOMP? So you can be, current service is really excellent, or it could be good, or not quite sure where we are, or not so great at the moment. This is all anonymous, so just be, I guess, be honest and open. I've got 31 people. I think last time we had 33, so maybe there's a few more to answer. Okay, brilliant. Thank you for that. So I'm going to ask a big ask here. Basically, Menti only allows us to ask a few questions at a time. So I have to log out and log in with a different account, if you bear with me. And we will ask you one more question before we go on with the rest of the presentation. So the next part is, if you can join with a different code, and apologies that you have to join a different code, but technology makes us do this. So if you can join either with by scanning the new QR code for the next lot of questions, or join with a new code. I'll give you a few seconds to do that. And then once you're in, you can start voting. Hopefully everyone is in and starting to vote. So I'm just going to go to the other screen and see if you can see the question. Yeah, so the first question is, how confident in terms of skills and knowledge do you feel in reducing psychotropic medications at the moment? Of course, this webinar, we aim to help you improve your skills and knowledge and your confidence in doing that. So you know, this is just a gauge of where we are, and hopefully by the end of this webinar or the few more webinars that we are providing, that you feel at a much better place to reduce psychotropic medication. So I can see the numbers are going up, so I'll give it a little bit more time for everyone to participate. Oh, I've only got 5 people. I wonder whether it's because you couldn't get in. Are people having difficulties joining the second lot of Menti? I don't know if anyone can pop in the chat. Obviously, I can't see because my screen is sharing, but maybe Tom can pop in the new code if it helps. Is anyone on the chat or anything? I can't see anything and can't hear anything. So do help me. Okay, so shall I stop here and carry on with the presentation? Oh, there's more people joining. Okay. So what I'll do is I'll move on to the rest of the presentation, and we'll move on to Tom.
Thank you, Trank. For this part of the presentation, I'm going to talk about the resources and guidance or the tools that we could potentially use when you are reviewing your patients with learning disability or autism. So first of all, just to mention about the Oliver McGowan, the mandatory training that has been launched for now, although they are still updating it. But if you are very keen on doing this training, learning more about learning disability and autism, then you are please feel free to sort of complete the training. But at the moment, we are still waiting for further guidance from above, just to find out when this training will be released fully in future, because it will be mandatory for everybody in the primary care workforce. But firstly, I'm going to talk about the guidance. If we could go on to the next slide, please, Trang. So first of all, we have the amazing guidance on mental health and LD drugs or psychotropic medication in general. So if you have the RPS, the Royal Pharmaceutical Society, or if you're a member of them, you can access the mostly prescribing guidelines in psychiatry for free. But otherwise, if you also pop the fifth prescribing guidelines with people with intellectual disability on the Google, you should be able to find the documents as well. So this is extremely useful for anybody who might want to look into learning more about the psychotropic medications and the diagnosis, treatment, recommendation around it. Just a very well-rounded guidance in general. If we can go on to the next slide. May I also suggest that all of the links on here should work, but if they don't, then you can easily copy and paste the title and then put it on the Google, and they should appear as well. So something very important for drug profiles when we are looking at reducing a psychotropic medication. So for instance, we will use antidepressant as an example. So if you wouldn't mind clicking onto Mind, comparing antidepressants. And if we go to the profile bit, so that link would take you to Mind website directly, and it just gives you a very easy access to drug profile in general. So let's just say if we are looking at reducing potential fluoxetine, which has got a long half-life, or a paroxetine, we have got an extremely short half-life. So these are the things that you will have to take into account when you are wanting to reduce, this medication. But I think Dr. Amy might be able to provide more information if there is any questions. Let's say fluoxetine has got a long half-life, so they can be reduced in a slightly shorter period of time. So maybe sometimes two weeks, or maybe even 4 weeks. But paroxetine, you may have to tailor it to the patient's needs or requirements, and to make sure that the patient is adapted to the reduction of the dosage first, because of the such a short half-life of the paroxetine, and that would help preventing a relapse on the, let's just say, behavior, and the the withdrawal symptoms as well. So that this is something that you might have to consider the drug profile in particular. If we can go back onto the slide, please. And there is also the NICE CKS, which again, it's very similar to all the guidance before in the previous page. If you are interested into looking into the mental health illnesses and the mental health drugs that's being used in secondary or community or the primary care, please feel free to sort of Google them as well. And next slide, please. So I just thought that some of the we rarely, and understandably as a pharmacist, we rarely use the diagnostic sort of criteria, because the diagnosis is usually done beforehand. But when you're reviewing whether a drug is still indicated, for instance, you see an antidepressant and you want to see whether they are still indicated, you would want to use, let's say, a Glasgow Depression Scale or the Anxiety Scale. Both of the easy read version are available, and if Chang wouldn't mind opening the Anxiety Scale so that we can show everybody the tools that we could potentially use when you are reviewing the antidepressant and the indication. So this is a scoring sort of system where you could potentially send it to, or you print it out and send it to the patient before they come to your annual health checks or the SMR review. And or if you want to go through it with them during the annual health checks appointment, this is you feel free to do that, because it should be an easier way of doing it now with the easy read version of the scale. But in general, what it does is it tells you whether the patient has still got the issue with, let's say, the anxiety or the depression, and therefore gives you a hint on whether the psychotropic medication is still indicated. But just to bear in mind again, then, if you don't see a mental health indication such as anxiety and depression, and when they're on antidepressants still, just be aware of that the antidepressants is also licensed for the primary chronic pain as a diagnosis as well. So this is something to bear in mind, in particular in primary care. If we could go back onto the slide, please. And if we look at the next slide, please. So monitoring template is extremely useful when you are doing your annual health checks and the SMR with your patient. So let's just say if somebody has been prescribed a lorazepam PRN with no mental health diagnosis, and they have been on it for a little while, and you know that it is because of the behavior. So the two monitoring templates that we would use is the first one, ABC chart, and also the behavioral symptoms recording form, which is the bottom 3 as well. But here is the ABC chart. How it works is basically it stands for, A stands for antecedent. So there's an event where how it triggered the actual behavior. So we would want to know, we would want to record this in a detailed form, and then what sort of behavior. So behavior stands for the B. What sort of behavior that has been demonstrated or is requiring support from the patient or resident if they are in a care home, and what are the consequences. So what happened after the behavior, so whether we needed to have the PRN drug administration because of the behavior was too serious and that could cause harm to the patient or others, or whether we were able to de-escalate it via, let's say, a behavior plan. So this chart is extremely useful for review purposes, and if you are doing a potential onward referral to your psychology team, the clinical psychology or the mental health team, this is something that could people can bear in mind to use just to facilitate the referral that way, and to give more insight into the behavior to see how we could potentially support it without a pharmacological intervention. And if we could go on to the next one. So let's say pain. So I'll give a bit of background again. So a lot of patients with learning disability and autism is unable to express, or they are non-verbal. So pain is often something that is missed just because somebody is not expressive enough. So we have the two tool that we could use. So the first one is the RB pain score, or RB pain scale, or the other one is a PainNat, it's called, which are both on the slide where you can easily open. So basically how you would use it is you would give this to an observer. So it would be a carer or a family member, and then they can fill it out before your appointment of the annual health checks or the SMR, so that you would understand whether the pain has been an unmet clinical need, because there is always behavior associated with pain. So we were talking about people who might not be verbal, so who are not able to express or communicate, but they will show it in a behavior or other forms such as facial expression, for instance. So this just gives you additional hints whether this should be looked into as well. So pain has been something that people would want to focus on in especially the non-verbal patients. And then the fifth item, which is the Bristol stool chart. So we always know that antipsychotic could cause constipation, and alongside with all the other medication that could cause the constipation. So there was incident where a learning disability patient was it led to death because of the constipation and because of the fecal impaction. So this is something that we would definitely ask in an annual health checks, or when you see the patient doing an SMR, you would want to ask whether opening bowel has been an issue or not. I just wanted to emphasize that, and you can use the Bristol stool chart in order just to show the patient as well if they needed some photo or picture just to relate to that. So that will be an easy way for you to do that. And then the next tool that we're going to use is the second bottom, which is the when required protocol, or a template where it will be specifically useful if you have a, let's say, you're a carer or care home, even you're in a care home, supported living, or even domiciliary care with patients who requires the have the medication administered by an external person. So when Shank has nicely highlighted the bit where we would want to look into symptoms that the rest of them will express if the medication is required. So we wanted to establish whether a lorazepam, for instance, as an example, is PRN is required for the patient or not. So, but how do we know this? So sometimes we would have the ABC chart where we monitor the behavior, such as if it is a green reg rating it, if it is green, that it could just be normal verbal aggression, but no harm is being done to the patient or the surrounding. But it could be yellow, where it starts as a bit of physical aggression, or if it is red, where patient will start damaging the furnitures, or they could be harmed to the surroundings. So you will have to agree with the GP or the prescriber when this when the lorazepam should be administered for this patient, or should be offered to this patient, if a verbal de-escalation is not enough for the green category of behavior. But think about if we are using agency staff, then how do they know when they should be administering 1 or 2 lorazepam when? So this is something that for the team to think about, especially when you have got a care home in Pacific, and this can stay within the care home or the supported living as a guidance, as a protocol for them to follow after. So it's just promote a good practice and also a safe medication administration. And finally, we will move on to the next one, which is reduction or switching medication. So we talked about antidepressants a little bit earlier on, but benzodiazepine is also seen. You also see a lot of low dose benzodiazepine or higher dose benzodiazepine just for behavior use in primary care. So Ashton Manual is a good guidance on how we could potentially use this specific resource to tailor your reduction regime for your patients. Let's look at a bit of withdrawal resources. So let's say somebody is currently on, again, lorazepam daily. So let's say 2 milligram in the morning, 2 milligram in the afternoon, 2 milligram in the nighttime. So what do we do if the behavior is resolved, or maybe lorazepam is no longer indicated? So what you would want to do is, first of all, try and find out what the daily diazepam equivalent dosage is. So in secondary care, this can be done quite quickly, but in primary care, we have to be very careful, because community sector, we do not have that amount of support, in particular in primary care workforce or in the community teams. So making sure that we do not do it too quickly, and making sure that we can tailor to the person's need as well when we are adapting to their reduction regime, so that you don't want to break that trust, and we don't want that behavior relapse, so that they don't trust you to do that further afterwards. So this is to bear in mind, but this is a good reference what you would want to do if you have to convert the specific benzodiazepine into diazepam. So the benefit would be, because of the diazepam formulation or the dosage, it can go from 10 to 8 milligram to then to 6 to 4 to 2. So this is much better than a lot of other more potent benzodiazepines, such as clonazepam, for instance. So hopefully the ASHTO manual will be useful, and you can, again, like I said, click onto the link and it would direct you to that page already. Thank you, Trank. If we could go on to the next slide, please. And finally, just more of the side effects scale or template where you could use during your SMR. Some of those that are specifically important are the second one, antidepressant side effect checklist, or the Glasgow antipsychotic side effects scale as well. I just wanted to mention that. But bear in mind the Leicester adaptation tool, which is on the 5th item. You can easily Google it as well, but it tells you, the general awareness of the metabolic syndrome when you are on the antipsychotics, and so that you are you're mindful of when patient is on those, and you would want to ensure correct monitoring has been offered to the patient, your BP, HbA1c, cholesterol in general. So that's just wanted to bring that awareness to everybody. But next slide, please. I think that's it from myself, and I will hand it over to Dr. Amy, our consultant psychiatrist from SLAM.
Tom and Ashika, thank you so much. That's really informative. Thank you. So today, hi everybody. Most people call me Amy Uchendu. I'm Dr. Nwamaka Uchendu. Today, I just wanted to highlight some of the guiding principles that we use. I think Thomas talked about the resources that we use for monitoring and for looking after managing patients when they're on medication, and some of the things that guide us on how we sometimes prescribe or reduce medication or manage medication, especially where we prescribe psychotropics where there is no diagnosis. So for instance, if the person does not have a psychotic illness, but is on an antipsychotic medication for purely for behavior management, or is on benzodiazepines, not for anxiety, but for behavior management. Some of the guidelines from NICE and from the Royal College of Psychiatry. Next slide, please. So I won't go into this because we've gone into that already. This is why we're here, about stopping the over-medication of people with medication in people with learning disability and or autism. Next one, please. Next slide. Okay, so I think what the protocol we advise people to think about is, could any of the, just when you see a patient in the annual health review, could any of the medication be stopped? So it's normally useful if before they are discharged from secondary care, if there's an indication of their diagnosis. So you're looking at their diagnosis and you're thinking, can any of these medications, if they've been stable for a while, should we be thinking about reducing any of their medications? And then we think about the psychotropic medication. What's the lowest hanging fruits is what I call it. What's the easiest thing for you to stop? And sometimes it might be the benzodiazepines, because you can stop them slowly and then monitor and see if there is any side effects or any recurring behavior. And then if there is nothing coming back, then you can stop that and then start dealing with maybe the antidepressants and the antipsychotics as well. If the medication is stopped and you see a recurrence of the behavior, you might need to go back to the dose that they were on before. A lot of times, once they go back to the dose that kept them well, you might see that behavior goes again. But if you need to bring them back to secondary mental health services, usually we're happy to take them back once they are re-referred to us. But that's the normal kind of thought process we go through when we're thinking about taking them off medication. So this would be the algorithm to think about. Next one, please. Okay, so just to highlight some of the NICE and Royal College of Psychiatry guideline on the use of antipsychotics, so the use of psychotropic medications in people with learning disability. Next one. Next slide, please.
Have we lost Amy?
Okay. Oh, have you lost me? I'm here. Can you hear me?
Yes.
Yes, I can hear you now.
Okay. All right. So from the Royal College of Psychiatry, I think the standards for psychotropic drug prescribing is just to think about the rationale for prescribing. Again, we go with diagnosis. What are you what are you targeting? What's the behavior you're targeting? What's the diagnosis as well that you're targeting? It should be normally it should be clearly stated in our letters. Sometimes it's not always stated, and we try to improve on that. And also to think about the consent to treatment. Does the patient have the capacity to consent to the treatment they're having? And if not, it's just to document and also to indicate the best interest decision. And it doesn't always have to mean having a big meeting or anything. I think sometimes we do a lot of best interest decisions for patients that it just involves you talking to the carer and indicating to the carer what you think would be the best way forward to manage this behavior or to manage the presentation that they've brought to you at that point in time. It's just important to just document it. And then there should be regular monitoring. I think in primary care, we talk about annual health review. For us in secondary care, we often, when they're under us, we tend to see them 3 monthly or at the most 6 monthly to continue to review. Just so sometimes when they don't have a diagnosis, so you're prescribing off license, you rationalize why they are on the medication, but there's a need to continue to review that they continue to need that medication and they continue to present in a way that justifies the medication continuing. So at least a 3 months to 6 months review would be a good interval to see them. I think what's happened sometimes is that when patients are not seen for years, they can carry on some medications that, all medications have side effects, and especially things like benzodiazepines that after a while they might become ataxic and things like that. Is important to ensure that they're seen regularly. Next slide, please. Okay, so I just wanted to talk about a particular case that we reduced benzodiazepines from a patient. So this was the patient with severe learning disabilities, a 24-year-old young man who, when he came to us, he was already on risperidone for behavior management, and also he had school refusal and things like that. He had both severe learning disabilities and autism, and he was living in the family home. His behavior continued to deteriorate while he was with us, and at some point we put him also on clonazepam to help to manage that behavior. I think at some point, mom, who he was living with, indicated that she could no longer continue to manage him at the family home. So he was first of all moved to respite care in a care home, and thereafter then stayed on in the care home. And while he was there, what happened was that there was psychology going in before while he was still in the family home. But we identified that the design of care, the way care goes into the family, because with all the best will in the world, most family homes are not designed in a way to manage, to have that routine, the regularity, the changes in care, the way he needed those changes to be regular for him, to be predictable. And so we identified that he probably would manage better if he was in a care home where, you know, all those things were set up for him, which was what happened. So although medication was going in, psychological care was going in, a lot of things just did not start to change until he moved to the care home from respite. Then he stayed on there. And while he was in the care home, most of the behaviors that we were seeing, like pulling mom's hair, strangling mom sometimes, physical aggression, destruction of property, we saw a massive decrease in those behaviors. So we started to reduce the benzodiazepines, first of all. We successfully took him off lorazepam, clonazepam, and now we're gently reducing the aripiprazole. So what we started with clonazepam, we started with 0.5 reduction every 2 weeks, which he coped well with. Then we took him off it completely, and now we've started on aripiprazole, reducing aripiprazole slowly. Again, just doing it slowly to see whether there's a recurrence of those behaviors. And if there's no recurrence, again, we'll just reduce again. So we reduce by 5 milligrams, monitor him over the next month to 2. I think normally they advise to do it at least a month to see if there is any recurrence. But because he's seen every 3 months interval, that's the interval that we're going with at the moment. Yeah. Next slide, please, Frank. All right, so the next one I want to talk about was a young man, a 25-year-old young man who came to us with very psychosis. So he had some paranoid ideas. He was quite anxious. He presented with mild learning disabilities and again with autism. There were loads of interpersonal difficulties in the family home. As a matter of fact, I think most of the children who were in the home were known to social services and were on the protection register for concerns, a combination of concerns of neglect and abuse. So there were loads of things that were going on in the family home. At one point, Mr. G was actually admitted to Lewisham Hospital, Ladywell, because of the psychotic symptoms he was having. So we started him on antipsychotic medication. At the time, he did well, relatively well, on aripiprazole again. And while he was on the ward, he settled significantly and was moved from inpatient care to a placement in the community. And while he was in the placement, he remained well for quite a while. So we decided to start reducing antipsychotic medication just to try out to see whether, while he was in that environment and being taken care of, when he had been removed from some of the social and environmental factors that were impacting on his presentation, whether he would remain well. So there was a combination of both psychology service going in to help with managing, just ensuring that his behaviors were well understood and that there was a PBS plan to manage him appropriately. And once that was in place, we started to reduce the antipsychotic medication. So we went down up to 2.5 milligram. And as soon as we went up to 2.5 milligram of aripiprazole, he became quite irritable again, became aggressive. And we thought that actually that this was that the dose where he remained best well on was the 5 milligram. So we took him back up to 5 milligram, and most of those irritability, the verbal aggression and things all reduced again. So sometimes with medication, it's trial and error. Sometimes it's about being courageous enough to just, try. This person has been stable for a while. Is worth checking to see whether he's going to manage without the medication. And you do that, you reduce slowly, you check and see how he's responding to the change that has been made. And if it's well tolerated, then go down again. And if he's not tolerating it, then go back, increase to the dose where he remained well. And that's where we're at with him. His medication has been increased back up to 5 milligram, and he coped well with it. And we've left him on 5 milligram of aripiprazole. Sometimes it's good to have some of that history so that if he comes back, even if he's discharged from our service and he comes back years later or whatever, it's good to know, and not lose some of that history. So yeah, that's where we're at. Those two examples just to show how we've reduced medication from somebody. And I don't know if you have any questions. Hi, Lely.
Thank you so much, all three of you. What an amazing presentation. And I think everything fitted in quite nicely. I've got like a couple of questions. The first one is, I was quite excited about your list of resources, Thomas, that you brought up. And I was just thinking, as a generalist, so many of us are not specialists in mental health, so we might not be bold enough to do some of the stuff. But I was just thinking, for example, the anxiety scale you talked about. So if I'm a primary care pharmacist, I've looked at that, I've found out that the patient is a bit stable or they've gone down on the gas. What happens next? Because I think this is where people who are not specialists struggle. What should we do? Does that mean we need to stop the medicines? Does that mean we need to have a conversation with someone? And I think just a little bit of guidance there would help. And I think some of that played out in Amy's example. So that's the first thing. And then the other thing I was just going to say, so I guess what I was just going to say, what principles can an inexperienced non-specialist, how can we work with that? And then who can we refer to, and how do we manage some of the fears that we have? Because I know Amy just said we need to be a bit courageous, and how courageous can we be without being risky? So just a little bit of that to guide. If I'm a clinician, I want to really take this on board and start doing good stuff. What would I need to be aware of?
Thank you, Lily. If I may answer this question, then please feel free to chip in, Dr. Amy, as you can, Trank. So first of all, if you identified a medication, a psychotropic medication, such as your, antidepressant is no longer valid or indicated, so the first thing you would find out is, first of all, is that indicator for something else, such as what I said earlier, primary chronic pain issues, or were they previously prescribed by the Mental Health Trust instead? Because if that is the case, then I would usually prefer or ask people to be referred back into the mental health just in case there is a communication breakdown after, or if there was a loss in communication somewhere that is leading to this prescription being on the repeat list. But afterwards, then just wanted to emphasize that if you're not feeling confident, we as a LDA specialist prescribing team, myself, Ashika, and Trank, please do feel free to email us on our generic email. If Ashika wouldn't mind putting it on the chat box so that people are aware of it, please feel free to utilize us for that point of contact. And thirdly, which I thought your question, Lily, would bring it nicely into what I'm just going to share. So you are not alone in the primary care. Please don't feel isolated in all of this. You do have a lot of support in a general multidisciplinary team. So first of all, we have had we have Amy, Dr. Amy from the Mental Health in Learning Disability team in SLAM. We do also have something similar in Oxley team as well for the BBG Borough. Also, just to mention about the community learning disability team as well, we do have one from the Guy's and St Thomas's and also Oxley as well. And we will have the webinar, part 3 of the webinar next month on the 8th of February between 1 till 2, the lunchtime again, to talk about what the function is about, MHLD, how we could work together, how we could refer patients onto the community and what it entails, and what actually local authority could also offer into circumstances as well when you identified something that is not just medication related issues or incidents which might require local authority, such as housing issue, respite causing a behavior of concern. And that's the reason what you want to look into it as a holistic review rather than just the medication. But we are here to help you.
Fab.
Sorry, Tom, were you sharing something? I couldn't see it. I don't know if anyone else could see it.
Yeah, it's a poster. You can't see the poster that I'm sharing. Oh,
No.
okay. I'll put it on the chat box instead then in that case. But otherwise, this is on the 8th of February between 1 till 2. Doesn't look like I can
Trang, you're
share.
muted.
Sorry.
You're still on mute.
Oh, God. Apologies. I just said if there was any other questions, because I couldn't see because I was sharing screen. Lots of beeping.
No, don't seem to be able to email or send that flyer on here for some reason.
We will, yeah, I was going to say we will send it out to everyone. So do keep a lookout, but just put it in your mind that it's 8th of February, isn't it, Tom?
Yeah, it is.
Brilliant. So the last part, as we have 6 more minutes left, I just want to do the last bit of Menti before we say goodbye, to see where we're at, and hopefully, because we've gone through all the resources and hopefully you're not overwhelmed, but you're finding it very useful. And of course, Amy's examples of ways of thinking and trains of thoughts of how to tackle these cohorts of patients, hopefully you'll find that it will help you gain your confidence and more likely to reduce meds or feel more confident at doing this. So I just wanted to share my screen for the bit of the Menti. Sorry. Yes, so if you originally logged in for the Menti, it should be there already. If you haven't, do log in now for me, please. So I'll give you a couple of seconds to do that. And then I'm just going to hop into the Menti part and hopefully, yes. So lots of people have put in. That's great. I think everyone's replied. Yeah, that's great. Thank you so much for your all your participation. Can everyone see me now? Back to normal, yeah. Is there any other things in the chat that we need to address or any last business or anything like that?
I have just put it on the chat that our previous recording, part 1 for the learning disability awareness, and how you would, look at learning disability versus learning difficulty, just for, again, to prompt everyone. If you didn't manage to attend the first one, here you go.
Brilliant. And then once we get the recording for this one, we will circulate so that for those who couldn't attend, because I know today is a little bit of a difficulty for a lot of people because there's strike on, and also people had Teams issues as well, accessing Teams. So for sure, we'll send the recording round, and do share it with your colleagues, and really looking forward to the next lot, really. If you do have any queries or any problems or any thing that you think, yes, please do cover because I have difficulties with these, then please pop it to our generic email, and we can try and address those offline as well. Any last thoughts in terms of for Tom and Ashika before we log off?
I just want to say thank you to Dr. Amy specifically to be one of our key speakers today. Thank you for coming, everybody.
Thank you. Thank you. And to emphasize that, refer to us if you need to. And maybe, Tom, I will forward our referral, if I haven't already, how to refer to the learning disability team.
That would be great if you could. Then in that case, then I can share it with everyone, as well as the slides and the recording too.
Okay.
Brilliant. Great turnout. Thank you so much, everyone, and have a lovely day.
Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you.
About providing inclusive information. So do we provide written information for easy format so that, you know, patients are more likely to read, more likely to understand the information they're given about their appointments, about their procedures and their results? Reasonable adjustments to the environment. So we know clinics are often busy, noisy places, and it can be
as we started promptly. But if this is your first time attending the network, just a bit of background. The aim of these sessions is really to deliver education and training on medicines optimization and long-term condition priorities. So this is through the share of guidelines, or you get presentations from some of our specialist teams, looking at shared care decision making as well. So thank you for joining today. Today we have our specialist, our learning disability pharmacist advisors, who are going to be presenting a presentation today on learning disability and STOMP awareness. But what I wanted to do firstly is just give a bit of housekeeping rules. So the session will be recorded, so it's recorded now. So if you don't want to appear on camera, please do switch your camera off. Also, just to reduce background noise and echo, if you're not speaking, please could you put your microphones on mute. The session today will be very interactive. We'll be making use of Menti, so please do log in and enter Menti and participate in some of the interactive sessions we have today, and there'll be designated time at the end for questions. So without further ado, I will introduce Tom, who will get started on the presentation.
Thank you, Charlene. So welcome everybody, and we will start with, can we have the next slide, please, Charlene? Thank you. So this is our team, and so as you can see in the photo already, Rena, who is unable to join us today, but she is our overarching LDA strategic lead. So she leads on all the development aspect of learning disability on autism in the medicine optimization sort of element, and she's also our associate director in MedSop as well. And we have Ashika and Trang who saying hello to you already on the screen if you can see it. So they are having a job share and supporting the LS Elbows in particular, and you have myself supporting the Bexley, Bromley and Greenwich area. So if there is any sort of queries whatsoever, there is our poster on the left side, which we'll share again later on after the presentation. Then at least you will get our generic email address. But the poster also includes a lot of role and responsibility, or our remit as well. If there is anything that you need to ask us about those, please either pick up the phone or just speak to us via the generic email address. Please, may I have the next slide, please? So 3 main sections today. So first of all, we will talk about the learning disability and learning difficulty aspect of the general LDA. What are they? How do we distinguish them? So they're your blue and pink bubbles on the slide, which leads to the next part, which is the register validation. How should we be adding a specific patient onto the LD register, or who should be considered as having a learning disability? Then the second part of the presentation,
or you get presentations from some of our specialists
in particular, and you have myself supporting the Please excuse me, I am just going to download the recording.